Your doctor didn't miss your sleep apnea. The test did. Over 90% of women with sleep apnea will never be diagnosed, and women with untreated sleep apnea have a 28% higher mortality risk, compared to just 3% in men. The reason is not biology. It's a test built 50 years ago on male data that is still the default for women today. In 2025, a new study finally proved what female sleep researchers have been shouting about for a decade. In this video, I'll show you exactly why the standard tests miss you, the 3 specific words to say at your next appointment to flip the result, and the 6-step protocol to secure the right diagnosis and the right treatment. Let's go. Before we get into it, subscribe to the channel. Every week I pull one sleep paper and turn it into a protocol you can actually use. That's the whole deal. And if you're a woman who's been told your sleep is fine when you know it isn't, or you care about someone who has, hit like. It tells YouTube to show this to another woman who's been dismissed. If you're a woman over 45 watching this, you probably know the feeling from the inside. You're exhausted, not normal tired, bone tired. You wake up feeling like you barely slept even though you were in bed for 8 hours. You have morning headaches. Your mood swings. You get up once or twice a night to pee. Coffee doesn't touch it. You go to your doctor. You describe all of it. And somewhere in that conversation, you hear one of these phrases. It's probably just menopause. It's probably anxiety. Let's talk about depression. Have you tried better sleep hygiene? I want to pause there, because being disbelieved by the person you went to for help, that's its own injury, not a clinical injury, a trust injury. And after that happens, 2 or 3 times, most women stop going. They stop asking. They start assuming this is just what 55 feels like. I see you. You're not imagining this. And what we're about to talk about is the reason. Here's the mechanism. The entire diagnostic pipeline for sleep apnea, the screening questionnaire, the definition of what counts as an event, the home test device, the insurance rule, all of it was developed on male patients in the 1970s and 80s. The classic sleep apnea picture in your doctor's head is a 50-year-old overweight man who snores and gasps and falls asleep during the day. You don't match that picture, so you get filtered out at step 1. Here is the number that should change something for you. A 2025 study in the Journal of Clinical Sleep Medicine applied an expanded diagnostic criteria to the same patients. Female diagnoses jumped 30% in the same people, same disease, different scoring rule. That is the entire problem, summarized in one number. 30% of women currently being told you don't have sleep apnea actually do. That is not a rounding error. That is a diagnostic crisis. And once you understand how it works, you can walk into your next appointment with the exact language to correct it. To understand why the test misses you, you have to understand 3 things. Women's airways are physically different. Women's respiratory events look different on the readout, and the rule that decides what counts as an event was written for the events men have, not the events women have. Physical difference first. Women have smaller upper airways, narrower by default, a diaphragm that is about 9% shorter and measurably weaker, and what researchers call a lower arousal threshold. Your brain wakes up from smaller breathing disturbances than a male brain does. That last one sounds protective. It isn't. Here's why. A man's airway narrows, his oxygen drops 4 or 5%, and the classic apnea event is scored cleanly. A woman's airway narrows. Her brain wakes her up before the oxygen drops that far. The event is shorter. The desaturation is smaller. The event still fragmented her sleep. The standard test just doesn't see it. Second piece, REM sleep. The dream stage. During REM, your muscle tone drops almost to 0. If you already have a narrow airway and a weak diaphragm, REM is exactly when you'd expect your breathing to fall apart. And in women, it does. A study of almost 300 consecutive patients found that REM-predominant sleep apnea occurred in 26% of women versus 9% of men. That's almost a 3-to-1 difference. Women with REM-dominant apnea often have a normal overall apnea-hypopnea index, The overall event count looks mild, but during REM, the numbers spike. Their symptoms are severe, and almost nobody tells them to look at the REM slice separately. So if your sleep study came back mild or borderline, ask for the REM AI specifically. An overall number of 10 with a REM number of 40 is not mild disease. It is severe disease that your report is averaging into invisibility. Third piece, and this is the big one. This is the rule that defines whether your sleep disturbance counts as sleep apnea at all. It's called the hypopnea criteria. A hypopnea is a partial airway collapse. Breathing doesn't stop completely, but airflow drops significantly. The question is, when do we count it? There are two definitions. The Centers for Medicare and Medicaid Services, CMS, which drives what insurance covers, says the event has to cause a 4% drop in blood oxygen. The American Academy of Sleep Medicine, which runs the clinical guidelines, says either a 3% drop, OR and arousal from sleep, counts. That 1% difference, and the word arousal, is the whole story. Remember what we said about women's events. Shorter, smaller desaturation. Arousal-driven. The CMS rule was tailored to catch the male pattern. It systematically fails the female pattern. The 2025 JCSM paper made this explicit. Applying the ASM rule instead of the CMS rule, female diagnoses went up 30%. Male diagnosis only went up 21%. The gap is real, and it is measurable, and it is entirely fixable. Now, the home sleep test. The small device you bring home, strap to your chest, wear for one night, mail back. Convenient, cheap, insurance loves it, and deeply unreliable for women. The home test cannot detect sleep stages. It has no EEG, no brainwave recording, so it cannot tell REM from non-REM. It cannot identify arousals. It reports what's called the Respiratory Event Index, not the true AHI, and the device assumes you slept the whole time it was recording, which you didn't. Sensitivity to moderate sleep apnea is somewhere between 40 and 70%. 18.6% of people with moderate disease on a full lab study come back from a home test classified as no OSA. For women, that 18.6% is conservative. Because female events are so concentrated in REM, and REM recognition requires EEG, the home test is structurally blind to the exact events that define female sleep apnea. You can have severe REM-predominant arousal-driven OSA and walk out of a home study with a negative result. One more piece: menopause. Estrogen protects your airway. It stabilizes sleep, promotes deep sleep, and reduces nocturnal arousal. Progesterone boosts the genioglossus muscle, the main upper airway dilator muscle. When estrogen drops 90% at menopause, the pharyngeal airway lengthens about 11 millimeters in women. The same aging in men? 4 millimeters. That's a sex-specific anatomical change that specifically increases airway collapsibility at exactly the age most women are also getting told. Their fatigue is just menopause. Let me say that plainly. Menopause doesn't just mimic sleep apnea symptoms. It actively causes sleep apnea in women who never had it before, and the diagnostic criteria that would have caught them still aren't being applied. And why does this matter enough to build a whole video around? Because Danish registry data following over 75,000 sleep apnea patients for up to 15 years showed that women with untreated OSA had a 28% higher mortality risk. Men, 3%. The gap was significant for women, not significant for men. Untreated female sleep apnea is a much more dangerous disease than untreated male sleep apnea. And nearly all of that danger is preventable if you get a real diagnosis and hit CPAP adherence of 4 hours a night. Before the protocol, I need a question answered in the comments. Which of the female OSA red flags hits you hardest? The unrefreshing sleep, the morning headaches, the mood shifts, the nocturia, the insomnia that no sleep hygiene fixes. I read every single one. Your answer shapes the follow-up video I'm already planning. And if this has been useful so far, hit like. It helps the algorithm show this to another woman who's been told her sleep is fine when it isn't. 6 steps designed to walk you through the exact doctor conversation, the exact test, the exact score, and the exact treatment path. Print this if you need to. Bring it to your appointment. Step 1. Problem entry. Here's what most women get wrong about sleep apnea. They assume the symptoms have to include loud snoring. They don't. The female-specific red flags. Count how many of these apply to you. Unrefreshing sleep, no matter how long you sleep. Morning headaches. Waking up more than once a night to pee. Brain fog or cognitive slowing. New mood symptoms. Anxiety or depression. After 45. Low libido without another obvious cause. Insomnia that good sleep hygiene doesn't fix. Jaw clenching or teeth grinding at night. If you have 3 or more of these, you are in the sleep apnea screening zone, whether you snore or not. Do not let a checklist that asks, "Do you snore loudly?" filter you out. The stop-bang questionnaire that most clinics use was validated primarily on men. It misses women who don't snore and women who don't have obvious witnessed apneas, which is most women. Step 2. Contrast entry. This sounds like you're being a difficult patient. You're not. You're being an accurate patient. If your doctor offers you a home sleep test, here is the exact language to use. Given the female-specific REM and arousal pattern, I'd like an in-lab polysomnography, not a home test. Say it calmly. You are asking for a diagnostic test that actually matches your physiology. Any sleep doctor who is current on the 2024 to 2025 literature will not push back. If they do push back, that is information about the doctor, not about you. You can ask for a referral to a sleep center that does in-lab studies. Those 3 words, in-lab polysomnography, are the single most important thing you can say. Write them down. Practice saying them out loud if you need to. That phrase, more than any symptom list, is what actually gets women diagnosed. Step 3. Result entry. What if I told you that the scoring rule your sleep center uses can decide whether you get diagnosed independent of your actual disease? Before your sleep study, ask the sleep center this: how will my hypopneas be scored? AHI, 3A or AHI, 4. If they say AHI, 4, or if they say the insurance rule, ask whether they can also provide the AHI, 3A score. Most good sleep centers score both and report them. The 3A number, the one that allows arousals to count, not just 4% desaturations, is the number that actually reflects your disease. If the HI3A shows you have sleep apnea, but the HI-AP4 doesn't, you are what researchers now call an H4N-OSA patient. Disease by the modern rule, no disease by the old rule. The MERGE trial showed these women get substantial quality of life improvements from CPAP. You are not a borderline case. You are a correctly diagnosed case using the correct rule. Step 4. Climax buildup. This is the step that will flip the most diagnoses, and almost nobody teaches it. When you get your sleep study report, there will be an overall AHI. There should also be a breakdown by sleep stage. Ask for it specifically if it is not there. The number you care about, as a woman, is the REM-AI. That is the event count per hour during REM only, not averaged. REM is about 25% of your night. If your overall AHI is 10 events an hour, but your REM-AHI is 40, you have severe REM-predominant disease that the average buried. That is treatable. That is the difference between being told you're mild, manage with lifestyle, and getting CPAP or a mandibular advancement device that will actually resolve your symptoms. Step 5. Origin entry. This latter comes directly from the 2023 International Consensus Statement on OSA and the female-specific treatment literature. If you have mild to moderate female pattern OSA, the treatment options in roughly this order. Positional therapy first. Many women's REM events are supine dependent, meaning they cluster when you sleep on your back. A simple positional trainer that keeps you off your back at night can cut events substantially. If that isn't enough, a mandibular advancement device, a custom oral appliance that repositions your lower jaw forward during sleep, fitted by a sleep dentist, works best for mild to moderate disease, weight loss in the range of 5 to 10% of body weight, produces measurable AHI reduction independent of treatment. Hormone replacement therapy is a conversation with your gynecologist specifically about airway-related benefits. The evidence is mixed, but in some postmenopausal women with OSA, HRT improves both airway dynamics and sleep quality. This is not a blanket recommendation. It's a conversation worth having if you're in the right profile. For moderate to severe disease, CPAP is still the gold standard. I know CPAP has a reputation. A lot of women have tried it, hated it, quit. We'll get to why that happens and how to fix it in the next section. Step 6. Problem entry again. Here's what almost everyone misses about CPAP effectiveness. CPAP adherence. Most machines report it. Many women, many men too, are running at 2 to 3 hours a night. And then they conclude CPAP doesn't work. It works. But the protective effect on mortality, on cardiovascular events, on cognitive function, all of that kicks in at about 4 hours of nightly use. Below 4 hours, the gap doesn't fully close. Pull the data. Your CPAP provider can send you a report. Look at average nightly use. If you're under 4 hours, we need to solve the comfort problem, not abandon the treatment. We'll cover that now. 6 steps, female-specific red flags. In-lab polysomnography, AHI, 3A scoring, REM AII breakdown, treatment ladder, CPAP adherence at 4 hours or more. If you bring this framework to your appointment, you will be ahead of 80% of sleep clinics. Let's talk about why the right diagnosis doesn't always turn into the right outcome. This is the barrier section. And for women with sleep apnea, there are 3 hidden traps that cause most failures. Mistake 1. The mask. CPAP masks, until very recently, were designed for male facial proportions. A nasal mask fitted on a smaller female face leaks, pushes at the wrong angles, and turns every night into a fight with the equipment. If you hated CPAP the first time, there's a very good chance you had the wrong mask. Modern manufacturers make female-specific designs. Nasal pillows instead of full-face masks. Softer silicone. Smaller frames. Ask your DME provider, that's the durable medical equipment supplier, for a mask fitting. Try 2 or 3 before you decide CPAP is not for you. Most women who quit CPAP in week 1 would have stayed on it with the right mask in week 1. Mistake 2. Pressure. Auto-adjusting CPAP, APAP, often starts with pressure ranges calibrated for average body weight and male anatomy. For many women, the default range is too aggressive. Ask about a titration study, or ask your sleep doctor to set a narrower pressure range tuned to your actual events. Lower pressure plus expiratory pressure relief, a feature called EPR, makes the therapy dramatically more tolerable without sacrificing efficacy. If your pressure is set at 15 and your symptoms resolve at 8, you don't need to wear 15. Mistake 3, and this is the specifically female one, co-occurring insomnia and sleep apnea. About 1/3 of women with OSA also have insomnia. Putting a CPAP on an insomniac doesn't cure the insomnia. She still can't fall asleep. Now she's anxious and wearing a mask. 3 weeks in, she quits. The fix is layered treatment. CBT-I, cognitive behavioral therapy for insomnia, runs in parallel with CPAP. Fresh 2025 evidence shows CBT-I actually reduces apnea events on its own by raising the respiratory arousal threshold. The 2 treatments work together. If you only treat one, the other sabotages your adherence. So if you've been on CPAP and you feel like it's not working, before you quit, run through this checklist. Right mask, right pressure. Is there insomnia on top of the apnea? Most failures are fixable. Most women don't get told this. Here's your recap. Screen yourself with the female-specific red flags. Demand in-lab polysomnography, not a home test. Ask for HI, 3A scoring, not just AHI. 4. Get the REM-AHI reported separately. Walk the treatment ladder in order. Hit 4 hours of CPAP adherence, and if you struggle with the mask, the pressure, or the underlying insomnia, fix those, one at a time, before you consider quitting. I put this entire framework, including the exact doctor appointment script, a printable symptom screener, and the questions to ask your sleep center before your study, into a free 7-day guide called the Adrian Mercer Sleep Protocol. It's the same playbook I'd hand to any woman over 45 in my life who's been dismissed. Drop your email in the description and I'll send it over. No subscription, no charge. It walks you through the framework night by night. Night 1 is the red flag screen. Night 2 is writing down what to say at your appointment. Night 3 is preparing for the sleep study. By night 7, you have a clear diagnostic and treatment path built on the 2025 evidence, not the 1985 textbook. If you want to go deeper on one specific piece of this, the cortisol and hormone interaction between perimenopause and sleep, I have a full video on that. The link is in the description. It pairs with this one. Before you close out, tell me in the comments. If you've been told your sleep study was normal and your symptoms weren't, I want to hear your story. I read every comment. And if you're about to have a sleep study in the next few months, drop a note. I'll be running a follow-up video specifically on navigating the appointment, and your questions will shape it. Subscribe and hit the bell. New sleep science every week, written specifically for the bodies the research has historically ignored. I'm Adrian Mercer. Sleep well.